BCH DNB Fellowship in Pediatric Critical Care in Australia. She is a Senior Consultant Intensivist and ER, Apollo Cancer Hospital. She's area of expertise is hematopoietic stem cell transplant, trauma, ECMO. Experience of 30 years in pediatrics, 23 years in intensive care. Teacher for Pediatric Critical Care Fellowship Program. Examiner for Royal College Emergency Exam. Several publications in international and national journals. Books in IAP textbook of pediatrics. Awards, Associate Professor Apollo EHERF. With this, I introduce the speaker for the session. Thank you, madam.
Thank you, Dr. Sriram. Good afternoon, everybody. I thank the organizing committee, Dr. Sendil, Dr. Thirumurugan, for this invite. It's so nice it's kind of hopefully ending the pandemic. It's nice to see so many familiar faces. My topic is all thugs are not bugs. So I'm just going to share a couple of case scenarios which were great sepsis mimickers. I will not dwell too deeply into one particular case, but just kind of, give a gross overview. So this was a 10-year-old girl, fever of 2 days with fits. She had a septic shock. I mean, she had shock, pretty similar to septic shock with wide pulse pressure. Her sodium was low, her liver functions were deranged, renal functions were deranged. Her CRP done outside was only 4, but at admission was 192. Somebody had just spoken about CRP. Of late, we are all doing CRPs. An echo showed myocardial dysfunction. So this turned out to be multi-system inflammatory syndrome. Of course, she got her share of antibiotics, cultures and all taken. But this is something that we have to keep in mind. And it has a wide spectrum. And this is from the IAP. We have the classic, criteria to define MISC. Now remember, every child may have antibodies to COVID. So you should not be categorizing them into MISC unless they fulfill the other criteria. So how do we treat MISC? It is steroids. IVIG is expensive, so we don't give it upfront. We reserve it for very sick children. So if they have severe shock, life-threatening, then they get the 10 per kilo methylprednisolone, otherwise just the 2 per kilo. All sick children do get the anticoagulation, so either aspirin or the heparin, depending on their echo and their aneurysms and their severity of shock. So Kawasaki is another thing that is also now increased during the COVID times. So what is the difference between MIS-C and Kawasaki? So Kawasaki is in younger children, MIS-C a little older and adolescent, gastrointestinal disease, symptoms common, organ dysfunction. And MIS-C has lymphopenia and thrombocytopenia. You have thrombocytosis in Kawasaki. The other clinical syndrome that I wish to share is toxic shock. We shouldn't forget this. Even here you have rash, you can have multi-system dysfunction. And here, apart from the antibiotics for staph, anti-staph and anti-strep, you also need to give the antitoxin. So not only treat the bug here, but the thug here is the toxin, because if you don't give antitoxins like clindamycin or linezolid, even the toxins can actually cause organ damage. Next scenario, here a child with 1.5-year-old with fever and painful swelling of the left index finger. Had a loose stools few days ago, was tachycardic but was otherwise reasonably okay, and you can see the swollen digit. ESR was high, but the X-ray showed the bone was normal, there was only soft tissue swelling. Any guess? So it seemed like osteomyelitis, but this was sickle cell dactylitis. So reported in trait as well, and this is the age group that can present 6 months to 2 years, and we all know this is because of the stasis and sickling causing obstruction. So another case, a child with dengue. We all treat dengue. Now there's an increase. So child got better with fluids. Again, the fever recurred. And child started looking ill. Cultures taken, antibiotics started, the counts were low, platelets again low, liver functions a little deranged. Any guess? What do you think it was? The ferritin was really high. So this is, we all know this word, the hemophagocytic lymphohistiocytosis, a pretty mouthful. terminology. Now, high ferritin can be part of dengue infection in the acute phase itself. So we've had 42 children with dengue, and we've just analyzed their records in the last few months. All of them had high ferritin in the acute phase when they came with shock, even to the tune of 50,000. And it all settled with just fluids and, multi-organ system support. So you don't really need to treat ferritin. Ferritin is a marker of the severity of the dengue or the sepsis. Only 2 of them out of the 42 needed steroids and IVIG. Now this is the new HLH 2009 criteria, because very hard to prove hemophagocytes from the bone marrow. So there's only clinical: fever, splenomegaly, cytopenia, or hepatitis. You should fulfill only 3 of the criteria and at least 1 lab criteria. So even a high ferritin is good enough. So now coming to the next case, 12-year-old girl with SLE, fever. She had jaundice, progressive drowsiness. She came with bounding pulses, abdomen distended. She had NG aspirate blood. Her counts were low. ESR was low. Liver functions and kidney functions were deranged. Any guess to what this child had? With a low ESR, you would expect high in SLE. So here the ferritin for this child was high and fibrinogen low. So this was macrophage activation, which is actually a spectrum of this HLH, and you call it MAS when somebody with autoimmune condition has this syndrome, and these are the criteria for macrophage activation syndrome. So HLH can be familial, genetic. It also presents like sepsis, fever, pro-inflammatory markers elevated, and it can occur secondary to malignancy, infection, or autoimmune, where it is called MAS. Now, coming to another case, a different 6-year-old boy. He hurt himself while riding bicycle, was admitted in a nearby hospital, and then 3 days later was referred to us with fever, fast breathing. He looked very ill. He had tachycardia, tachypnea, wide pulse pressure, like shock, in fact like septic shock. He was febrile, abdomen was distended. We took cultures, started antibiotics, but what did it turn out to be? His WBC counts were high. He had hemo concentration. CRP was high. Liver function, kidney functions deranged. Any guesses? His amylase was normal, but lipase was elevated. Now, amylase has got a very short half-life of 24 hours. So this was a child with traumatic pancreatitis, which can mimic sepsis because you can have the systemic inflammatory response, and he just needed supportive care. So coming to the next case, a 12-year-old girl, fever of 2 weeks duration. Here also abdominal pain, vomiting, irritability, and she was very drowsy. ABCs were stable. Abdomen mild hepatomegaly, counts elevated, hemoglobin was very low, platelets also low, liver function was okay, urea creatinine deranged. So she basically had low hemoglobin, low platelets, renal functions deranged, and she was drowsy. CT brain normal, CSF analysis normal, and fever. Any guesses to this? So this ferritin was 3,000, smear showed hemolysis. So here you have a child with anemia, hemolytic anemia, thrombocytopenia, drowsiness, renal functions deranged. So this was thrombotic thrombocytopenic purpura. Her ADAM13 levels were the PITS 0.5, the range is 60 to 180. She underwent plasmapheresis and was also evaluated for SLE because it can be associated. So we all know what is TTP. This is the pentad of TTP, and it can occur with a host of conditions, either primary or with autoimmune disorders. So the next case, 15-year-old girl with fever intermittent for a month, and this was a very interesting child. Developed weakness and was transferred to our hospital, intubated because of refractory status epilepticus. But at admission, she had fluctuating blood pressure, so we had to put central lines, arterial lines, etc. Her counts were very high, CRP high, ESR elevated. Renal function was normal, CT brain showed a right MCA infarct. So she was given acyclovir, ceftriaxone, everything. And no one could even dream that this could be the diagnosis. Her echo was done, and it showed a huge mass in the left atrium. This was a child with left atrial myxoma. So left atrial myxoma can present with a lot of constitutional signs and high CRP. So she underwent immediate bypass, surgery done, and this is her just before discharge. So, and the CRP, everything came down once the tumor was removed. She was also put on anticoagulation. So I think it was just such serendipity. If we had not done the echo for fluctuating blood pressures, we would have missed the tumor and we would have treated as just like any other encephalitis or CNS problem. Now this was a 5-year-old girl with thalassemia, high-grade fever for 3 days, seizures, vomiting, good urine output. Her GCS was low. She came to our emergency department hypotensive, in fact refractory hypotension. We had to give her fluids, multiple pressors. Her blood glucose, she had refractory hypoglycemia. So refractory hypotension, refractory hypoglycemia, and high counts, was febrile, so she was intubated. And she received hydrocortisone vasopressin, and her brain, because she had seizures and was drowsy, we also did a CT brain. She was polyuric. She had 20 ml per kilo per hour of urine output. So we just couldn't explain what, and this was an otherwise well thalassemic child. This was an adrenal crisis with hypopituitarism, and this is her pituitary. It's an empty sella syndrome, very, very rare, and just hit us out of the blue. This was not diagnosed, probably it was just primary empty sella syndrome, but that's something to be kept in mind. Adrenal crisis should be kept in mind if a child comes to you with shock, mimicking septic shock, because you can have any viral infections or anything triggering this event. And her cortisol levels are very, very low. So the next case, a 3-year-old girl, fever, drowsiness, had seizures, no cough, no other symptoms, was otherwise okay, a little irritable except, she had 1 or 2 seizures, but otherwise was responding, kind of oriented. Liver was palpable. So fever, seizures, so got all the usual encephalitis workup and anticonvulsants. Her WBC count was 1 lakh. So, and she had been referred to us. Platelets were low, so we all know this is hyperleukocytosis with leukostasis syndrome. So when you have very high WBC counts, they can sludge your cerebral capillaries, your lung vessels, and cause leukostasis. So you can have infarcts, you can have, so any child with infarcts, seizures, please do look at the counts, screen for blast. And AML blast can actually cause more sludging of your capillaries than ALL, lymphocytic. This was a child with burns. Now we all manage burns kids, and they can have fever. They can have fever due to multiple reasons. So this child developed fever on day 2. Child was cold, tachycardic, pulses feeble. Burn wound was healthy. Good, the urine output, perfusion, everything improved after fluids, so she was probably hypovolemic. Now this child has fever. Do we need antibiotics? So burns kid on day 2, does she need antibiotics? So there are very strict criteria when to give antibiotics in burns. So progressive tachycardia, tachypnea, thrombocytopenia, that is after 3 days, hyperglycemia, or inability, intolerance to feed. So systemic inflammatory response is very, very common in severe burns. You don't need to give antibiotics because then that will cause overgrowth of, resistant bugs. So you just have to remember that and keep a close watch. As long as the wound is healthy, the chances of infection is very low. The next case, 8-year-old boy with high fever for a month, bouts of vomiting, loss of weight. So he had lost a lot of weight, he was frail, dull, but otherwise no grossly, there was nothing grossly abnormal. His blood counts were normal, CRP normal, chest x-ray normal, ultrasound abdomen normal. Can you take a guess what this boy had? Fever, and he was losing weight, bouts of vomiting. So this was a hypothalamic tumor. There was a glioma there, and that was removed. So keep that in mind if there's fever of unexplained reasons. 10 months infant with intermittent fever, failure to thrive, pallor, striking pallor, distension of abdomen, Child was very anemic, tachycardic. So when the child came here, the child had fever, low hemoglobin, was very pale. Platelets were also low. Kidney functions and all were normal. Any guesses? Low platelets. The counts were high. So we did look at the smear and there was a lot of hemolysis, Jayakumar's test. And each episode, if you see this is the chart, so each episode of fever, hemoglobin would drop. So you can, hemolytic anemia can also cause fever when you have the hemolytic crisis. And you don't really need antibiotics. You have to look for this, probably child is actively hemolysing. So you can see this chart and the PRBCs down that were given. Like you have your febrile hemolytic transfusion reactions. Now coming to the next case, 8-year-old girl, fever for 3 weeks, lethargy, past tarry stools, was very ill-looking, icteric, tachypnic, tachycardic, abdomen distended. Here also counts high, platelets are lack, bilirubin high, liver functions deranged, urea creatinine all haywire, ferritin was around 6,000. Any guesses? This child turned out had this mediastinal mass. So the X-ray was just taken because the child was tachypnic, and there we saw this big mass. So what is it? So we did all the viral markers and all, we didn't have to send because it was a child with leukemia. T-cell, and then because of leukemic infiltrates in the liver, was actually presenting to us with fever and liver derangement, like liver cell failure. So all the NAC, everything was being given, and then we had to start giving chemotherapy. So coming to the next case, you have a 4-year-old girl, fever for 3 weeks, vomiting, loose stools, rash over the body, became very unwell. This child was on drugs for a known seizure disorder. Had maculopapular rash over body, was icteric, ill-looking, had lymphadenopathy, liver spleen enlarged, ESR, CRP moderately elevated, liver functions deranged, ferritin 4,000. Any clues? Yes, sir? Huh? So this child was actually DRESS syndrome, so drug reaction to the carbamazepine that the child was on. So DRESS is a drug reaction with eosinophilia. So here you have eosinophils and systemic symptoms. You can have multi-organ dysfunction and it can be life-threatening. There have been reports even with cefotaxime, clindamycin used for pneumococcal pneumonia, and then the child continued to have fever and multi-organ dysfunction, and it was actually DRESS. The treatment is stopping the offending drug as well as giving corticosteroids. So that's something to be borne in mind. Now, drug fever is pretty similar, but here you don't have the rash and you don't have eosinophilia. You may have eosinophils, but not eosinophilia. So any child with persistent fever, we also have to keep non-infectious causes when they are in our hospital, because any of the drugs can lead to drug fever, and here the inflammatory markers can also be elevated. You can have leukocytosis, elevated ESR, sometimes it may even reach more than 100. So we'll have to keep that in mind when we are treating our patients. So thank you all. I think I've just given you a brief overview of so many things that can mimic sepsis, but I don't want to say that don't think of sepsis. All these children got antibiotics, cultures taken, everything, but keep your mind open and look for other non-septic etiologies as well. Thank you all. Thank you for this opportunity. Bye.
Thank you.
Thank you, ma'am. It's actually a challenge, especially in our country, where if you compare our country with the West is infectious disease is almost a non-existent thing. And we in our country, we usually think about infections as the beginning of the first point of our diagnosis. It's always, I heard about it, there's something called Bhog and Mahabhog. Bhog means prasad, which is given in normal days. Mahabhog is given on big festivals. Generally, it's my experience, they said that Bhog is anti-malarial, Mahabhog is ATT. So there are times when we don't cross beyond that. And clinical diagnosis has always been a challenge. It's not a kind of, sometimes it's a very complicated thing. It's not a straightforward thing. As the morning session, Professor Director Mahadevan sir has highlighted in his talk, it sometimes is difficult. Maybe for even MBBS students level, we teach them how to analyze the cases. It's almost like Sherlock Holmes detective crime, where they detect a crime and we detect a disease. So diagnosis has always been a challenge, but even more challenging for those setups where investigation parameters are very weaker. Still today, the clinical diagnosis, clinical experience, examining patients, spending time with the patients, still in a settings where all the investigation parameters are not there, especially the many patients who can't afford so many investigations. For example, a couple of infections can also cause hemophagocytic syndrome, like dengue infection. So you have got different manifestation. Probably the key point is to try and pick up the clues, for important clues for reaching a diagnosis, so that we minimize the balance between spending money and lot of investigations, and at the same time coming to a point of diagnosis. All the case scenarios have highlighted a lot of things. It's probably an eye-opener where there is a general tendency to overdiagnose infectious diseases, and there is a severe attachment towards antibiotics. Once we give an antibiotic, probably we are too attached to it not to stop it. We don't autocorrect. Usually we don't autocorrect ourselves that this is a case that doesn't require an antibiotic, and that is where the rational antibiotic therapy comes in, and that is where the spectrum of other disease diagnosis becomes more easier. Thank you for the eye-opener session.
Thank you.
Any questions?
Yeah, it was indeed, thank you ma'am. Ma'am, you need to get a memento. Sorry ma'am. So, today was a day when we saw a lot of discussion on rational antibiotics, about infections, non-infectious conditions, and the last one was the ma'am Indira Jayakumar gave was where all we have pitfalls in our diagnosis, where we think a lot of them are sepsis, which are not really sepsis. Thank you ma'am. I request the chairperson, Dr. P. Sriram, to honor the speaker with a memento. Ma'am, could you please honor the chairperson with a memento? Ma'am.